Alveolar to arterial oxygen difference. This is definitely one of my favorite lectures and topics of this class. It's usually, at least last semester, I shouldn't say usually, I've only done this a couple times. It's usually pretty eye-opening, just giving you some different things to think about as you exercise and understanding what's going on. Okay, and so we talked about AaDO2 last time, and remember that's the alveolar to oxygen difference. So what we're going to talk about is identify the factors, and there's 4 of them that contribute to AaDO2, and then just talk about how these factors are affected by exercise. Okay, now there are 4 main causes, and when we talk about AaDO2, we usually talk about it widening or narrowing. If we talk about widening, that means it's getting bigger. That means the difference between alveolar oxygen and arterial oxygen is getting larger. Okay, normally it's about 5. Okay, but if it widens, it'll go to 10. And if it narrows, maybe it goes to 2. Now, these 4 things are something called VQ mismatch, diffusion limitation, which we've talked a little bit about in physiology, and then intrapulmonary and extrapulmonary shunt. Now, in my classes, we have talked about shunt before. You might not remember it, but shunt just means an area where we have blood flow, but we don't have any airflow. So in other words, we've got blood to pick up oxygen, but there's no oxygen to be picked up. Okay, and so we're going to talk about the first one, VQ mismatch. So we've got V is for ventilation. Okay, and so if we've got ventilation, that means we've got airflow. And then Q is for perfusion. Okay, and in that case, we have blood flow. Now, in a perfect world, they're going to be matched up. Where I have airflow, I'm going to have blood flow and vice versa. But this isn't the case. Physiology is not perfect. Everything is not lined up. There are going to be times where we have ventilation without blood flow, and there are going to be times where we have blood flow without ventilation. It kind of happens. Okay, and we see that from this diagram here. Now, when it comes to VQ mismatch, a lot of this is due to what we call zones of the lung. Okay, and so we can break the lung down into 3 zones. Okay, and what causes these different zones are pressure gradients. See, it all comes back to flow down gradients and pressure gradients. At the top of your lung, and as you can see, we've got it written here, alveolar pressure is greater than arterial pressure, which is greater than venous pressure. Because alveolar pressure is greater than arterial pressure, basically what happens is we pinch off, like you can see here, we pinch off the pulmonary capillary so blood can't go through it. So blood cells can't go through it. And if I don't have blood cells going through a capillary, I can't pick up oxygen. So there is relatively small amounts of gas exchange that occur there. In the middle of the lung, which is the largest zone of the lung, arterial pressure is greater than alveolar pressure, which is greater than venous pressure. Okay, there are going to be times where there isn't flow because the alveolar pressure is greater than venous pressure, so it kind of pinches off that vein. Okay, but pressure is not constant. Blood pressure is not constant, right? We have a systolic and a diastolic. And so what happens is there are times where the vein is forced open, and this can be due to contraction. This can be due to just the buildup of blood, which increases the pressure inside the alveoli, or inside the artery, the alveoli, and so it allows blood to go through. Okay, and then the last one is the bottom zone, and this is where we have continuous blood flow. So blood pressure, both arterial and venous, is greater than alveolar pressure. So another way to look at this is how gravity is gravity playing a role. So in zone 1, we have very low blood flow, but we have lots of airflow. And so what's happening is gravity is stretching the zone 1 alveoli the most. They're essentially constantly filled with air. Okay, and I'll show you in class about how use a slinky to kind of show you this analogy. Okay, now theoretically, with maximal alveolar distension, alveolar pressure is going to be greater than arterial pressure, and therefore you're not going to have blood flow through these pulmonary capillaries. This likely doesn't happen very often, but it happens some. Okay, then we've got zone 2. And with zone 2, arterial pressure overcomes alveolar pressure, so we have blood flow, but these alveoli, because they're distended or opened, is still greater than venous pressure. And so it might inhibit blood flow a little bit. But we have better matching in zone 2. Whoops. Sorry. And then we've got zone 3. Don't know what I hit there. So with zone 3, what's going on is we have high levels of perfusion, high levels of blood flow. Just think of gravity pulling all those blood vessels down towards the bottom of the lung. And so we have lots of blood flow, but the alveoli at the bottom of the lung, it's hard for them to fill up, so they're a lot smaller, so we don't have as much gas exchange there or as much ventilation. And so we have low VQ match there. Okay, I want to make clear, though, that in all of these places, we do have blood flow, we do have airflow. We're just talking in relative terms. Okay, so we estimate, there's no real easy way to measure this, but we estimate that in the lung, VQ is 0.8. Okay, so then we've got diffusion limitation. Okay, so if we have a diffusion limitation, we're going to have lower arterial oxygen. And so there are a variety of things that can cause this. Okay, if my respiratory membrane is thick, if I have a reduced pressure gradient, so think hypoxia. If my surface area is decreased, think smoking, COPD, that's the word I'm thinking of. Transit time is reduced. Okay, so this is how long the red blood cell is in the pulmonary capillary. So exercise is definitely going to affect that. Okay, so those are 4 things that can affect it. It will make it less. Now, generally speaking, we don't have diffusion limitation. In almost all cases, if you're a normal, healthy human, you're likely, rarely if ever, going to experience diffusion limitation, but it's a possibility. Then we've got intrapulmonary shunt. Okay, so with intrapulmonary shunt, there are these pathways that are in the lung that just bypass pulmonary capillaries. So we've got our diagram up here, and so notice that we've got capillaries. This bottom line is a capillary, but then this top line is what we call an IPAVA, and what that means is intrapulmonary arteriovenous anastomoses. You'll never have to spell that on a test, okay? But what happens here, notice that it's thick, okay? And so gas exchange doesn't occur there. Normally these pathways are closed, and that's what we're trying to show between A and B here, is that we just don't have blood flow through this IPAVA. They do, however, appear to open during exercise because pulmonary pressure has increased. That should say pressure, not just pulmonary increases. And this might actually be as a relief valve. One of the things that we don't want is we don't want pressure to be too great in the lungs because we could break the capillaries. Just imagine a water balloon that you put too much water in. What's going to happen? It's going to pop. That's not great. Okay, and so if I have more blood flow through these pathways, I'm going to reduce my arterial oxygen because I'm going to have blood that goes through like it is here, but it's not going to have picked up any oxygen. And so as a result, arterial oxygen as a whole will be reduced. Okay. The last one is extrapulmonary shunt. Okay, and an example of this is what we call a PFO, but extrapulmonary because it occurs outside of the lungs. So a PFO is an opening between the right and left atria that we all have before we're born, but that remains there in about 35% of the population. And so what happens is that this allows blood flow to go straight from the right side of the heart to the left side of the heart without undergoing gas exchange. Now, normally at rest, maybe 1 to 5% of your cardiac output, if you have a PFO, goes through the PFO. Generally, it's closed because of pressure gradients. Remember, left-sided pressure is greater than right-sided pressure. Okay, but what happens to the amount of blood that's coming into the right atrium during exercise? It increases. And as a result, there's going to be more pressure in here, and that helps to force open the PFO. And so that could cause even more blood to go through the PFO, which would reduce my arterial pressure of oxygen, which would mean I'm widening or increasing the AaDO2. The last thing that I want to talk about, I'm actually going to go back real quick to the VQ slide here because I didn't really talk about it, is during exercise, VQ might actually be, we're still trying to understand this, but you could make an argument that VQ should get better during exercise because what's happening is we're increasing pressure, which will allow blood to get up to that top part of the lung that doesn't have as good a perfusion. Okay, and so that might be what's going on with that. All right, so we're going to end there. That's the end of week 4.